Dear students, if you all remember when we studied on the posterior compartment of arm and posterior compartment of forearm, the nerve of these compartments is radial nerve. So injury to the radial nerve, it makes a gross difference because all the posterior compartment muscles, either directly or indirectly, they are supplied by the radial nerve. So if we see the origin of the radial nerve, it is the continuation of posterior cord of brachial plexus. So we know the root value of brachial plexus as C5, C6, C7, C8 and T1. So these ventral rami roots, they gives rise to trunks, and trunks divide to form divisions, and divisions joins to form cords. So here is the picture of the brachial plexus where we can see its origin, and all are roots. C5 to T1 are the roots, and roots are joining to form trunks, upper trunk, lower trunk and middle trunk, and each trunk divides to form divisions. And we can see the posterior divisions, all the posterior divisions of each trunk, they form a cord called as posterior cord of brachial plexus. And this posterior cord, we can see it gives several branches here. We can see it gives, and one of them is quite thicker, and it is the continuation of the posterior cord of the brachial plexus, that is the radial nerve. So now we know the posterior cord, it is formed from the root values of all, that is C5 to T1. So the radial nerve root value also C5 to T1. The ventral rami of C5 to T1, they form the radial nerve, which is the thickest nerve among all the nerves in the brachial plexus. So it is the largest nerve in the upper limb and most commonly damaged. And let's learn the radial nerve at each part. So we can divide its course in axilla, in arm, in forearm, and then finally how it divides into the dorsal surface of the hand. So first, starting with the axilla. So this is teres major muscle. So till the lower border of the teres major, it is considered as the axilla, and beyond the lower border, it is into the arm. So in the axilla, the radial nerve, it is related to the axillary artery. So this is axillary artery. So it is posterior to the axillary artery. So this is the axillary artery. So the radial nerve is here, which lies posterior to the third part of axillary artery. The branches given off in the axilla are posterior cutaneous nerve of arm, which supplies to the skin. So this is the posterior cutaneous nerve of arm, which is given on the posterior side, and nerve to the long head of triceps. So this is the long head of triceps. So a branch is given to the long head of triceps in the axilla, and a nerve to the medial head of triceps. This is the. So these are the branches given off in the axilla. Let's see the radial nerve in the arm. So in the arm, it enters the arm at the lower border of teres major and passes between the long and the medial head of the triceps, and it enters the groove. So this is the anterior view showing the radial nerve. So we can see the impression on the radial nerve on the posterior aspect like this. So this is the groove which lies between the medial and lateral head of triceps. So this is the radial groove or spiral groove, which lies posterior to the humerus, shaft of the humerus. So along with this radial or the spiral, there is a profunda brachii vessels also, which lie along with the radial nerve, and the radial nerve is in direct contact with the shaft of the humerus. So these things we have to remember in the arm. Let's see the boundaries of the spiral groove or radial groove. Anteriorly, we have got middle 1/3 of the shaft of the humerus. We can see what we are seeing is the anterior part. So anteriorly, it is related to shaft of the humerus, and above it is related to the origin of lateral head. So this is the lateral head of triceps. Above it is related to lateral head of triceps, and below it is related to the medial head of triceps, and posteriorly it is related to the fibers of lateral and the long head of triceps. So these are the relations of the radial groove and boundaries of the radial groove. In the radial groove it gives off 5 branches. Let's see those 5 branches. The first branch is the lower lateral cutaneous nerve of arm. This is lower lateral cutaneous nerve of arm. It supplies the lower lateral part of the cutaneous nerve. Next is posterior cutaneous nerve of forearm, which runs down. This is the posterior cutaneous nerve of forearm. The other branches are nerve to the lateral head of triceps. So we can see here, this is the lateral head, which is given off because they form the boundary of the radial groove. So it supplies, and nerve to the medial head of triceps. So one branch is given off in the axilla already. The second branch to the medial head of triceps is given off in the radial groove. Then nerve to 𝐒𝐭𝐻. 𝐒𝐭𝐻 is the posterior muscle, which is a deeper muscle, can't be shown in this picture. So the 𝐒𝐭𝐻 is also supplied by the radial nerve. Here in the radial groove it is given off. So nerve to 𝐒𝐭𝐻 passes through the medial head of triceps to reach the 𝐒𝐭𝐻. At the lower end of the spiral groove, the radial nerve pierces the lateral intermuscular septum of the arm and enters the anterior compartment of the arm, and the nerve gives nerve to brachialis, a small lateral branch. So it also supplies brachialis. This is a brachialis muscle. A small lateral twig is given to the brachialis muscle. Brachialis muscle is actually supplied by musculocutaneous nerve, but partly it is given off by the brachialis. And nerve to brachioradialis. So we can see here this muscle which is lying on the lateral superficial one. This is brachioradialis, which is also supplied by the radial nerve and is given about 3 fingers breadth above to the lateral epicondyle. Just 3 fingers above to the lateral epicondyle, nerve to brachioradialis is given. Here it first descends between the brachialis and brachioradialis, and then between the brachialis and extensor carpi radialis longus before entering into the cubital fossa. And let's see the nerve in the anterior compartment of arm above the lateral epicondyle. Above the lateral epicondyle, it gives already 3 branches. We saw it. That is nerve to brachialis, nerve to brachioradialis, and also nerve to extensor carpi radialis longus. So, extensor carpi radialis longus. So, these 3 branches are given off just above the lateral epicondyle of humerus. At the level of the lateral epicondyle of humerus, it terminates, finally the radial nerve terminates by dividing into 2 branches. One is the superficial branch, the other is the deep branch in the lateral part of the cubital fossa. So we can see here it divides into deep branch. So this is the branch and this is the which are given in the lateral part of the cubital fossa. So it terminates by dividing into superficial and deep branches. The deep branch is also called as posterior interosseous nerve. That you have to remember. Posterior interosseous nerve. And in the cubital fossa, it supplies 2 muscles, extensor carpi radialis brevis and supinator. So within the cubital fossa, it supplies supinator muscle. This is supinator. And also it gives off a branch to extensor carpi radialis brevis. So this is about the deep branch which is given off immediately within the cubital fossa. and after supplying these two muscles, it passes through the substance of the supinator and enters the posterior compartment of forearm and supplies all the extensor muscles in the forearm. So posterior introitious nerve, or the deep branch of the radial nerve, it is the nerve of the posterior compartment of forearm, because beyond supinator it supplies all the muscles on the posterior compartment of forearm. It also gives articular branches to the radioulnar joint, wrist joint and carpal joints. Whereas the superficial branch is also called as superficial radial nerve. It is a sensory nerve because it is a cutaneous nerve, and it runs towards the over the supinator, pronator teres, flexor carpi. So we can see here supinator, then it crosses pronator teres, which you can't see on the anterior side, anterior-posteriorly. This one is. So this is a pronated forearm. So we can see the pronator teres. We can see the supinator on the dorsal side. So we can see it divides to posterior introitious nerve, gives of all the branches to all the muscles on the extensor compartment of the forearm, and about 1/3 of its way down the forearm, that is around 7 centimeters above the wrist, it becomes cutaneous, completely cutaneous, and it passes posteriorly, emerging under the tendon of brachioradialis, proximal to the stylar process of radius, and then passes over the tendon of anatomical snuff box. So this is anatomical snuff box, where it terminates as a cutaneous branch, which provides a sensory innervation to the skin on over the lateral part of the dorsum of the hand. So you can see it gives off lateral to the dorsum of the hand and a dorsal surface of the lateral 3.5 digits. So 1, 2, 3, and we can see it is given of half here. So half of the 4th digit. So lateral 3.5 digits it gives, including the proximal to the nail beds. Okay, except the nail beds, proximal to the nail beds. The rest of it is supplied by the ulnar nerve, which is on the ulnar side of the front, and it gives on the dorsal side also. So let's see the injuries of the radial nerve. So injuries of the radial nerve you can divide into 3 parts, that is in the axilla, in the spiral groove, at the elbow. Okay, so first one in the axilla. In the axilla, the radial nerve, it may be injured by the pressure of the upper end of the crutch, that is called crutch palsy. So people who doesn't have one limb, they use crutches to walk. So when they keep the crutch under their underarm, so that time the radial nerve, because it is on the posterior side, it may get compressed in the axilla. So that is called crutch palsy. Characteristic features in such, there will be a motor loss, that is loss of extension of the elbow, because it is supplying the posterior compartment, that is to the triceps. So loss of extension of the elbow due to the paralysis of triceps, loss of extension of the wrist due to the paralysis of wrist extensors. So this causes wrist drop. To the unopposed, because of the unopposed action of flexor muscles, always it will be flexed like this, that is called as wrist drop condition. Then loss of extension of the digits, fingers extension is also lost due to the paralysis of extensor digitorum, extensor indicis, extensor digiti minimi and extensor pollicis longus. Loss of supination in the extended elbow, because the supinator and brachioradialis are paralyzed, but supination becomes possible if the flexed elbow, because the biceps brachii is not paralyzed, because it is supplied by musculocutaneous nerve. And there will be sensory loss on the small area of the skin over the posterior surface of the arm, because posterior cutaneous nerve is involved here, posterior cutaneous nerve of arm. So lower posterior cutaneous nerve, there won't be any sense, and sensory loss along the narrow strip on the back of forearm, and sensory loss on the lateral part of the dorsum of the hand at the base of the thumb and the dorsal surface of lateral 3.5 digits fingers. So all these areas there will be a sensory loss, and more often there is isolated sensory loss on the dorsum of the hand at the base of the thumb, especially if you see in the base of the thumb near the anatomical snuff box, there will be isolated sensory loss. Then let's see the injury of the radial nerve in the spiral groove or the radial groove. In the radial groove, the radial nerve may be injured because of mid-shaft fractures of the humerus and carelessly wrongly placed intermuscular injection. Sometimes it can happen because of wrong clinical practice, because of placing wrongly intramuscular injection, and direct pressure on the radial nerve due to drunkard falling asleep. Means it is also called Saturday night palsy. The people who have drunken, who had boozed already, so they keep their hand behind their armrest or behind their couch, and where the radial nerve may get compressed in the radial groove. So the symptoms will be similar only as the radial nerve compression at the axilla. Only difference is posterior cutaneous arm will be spared, and medial head of the triceps will have partial nerve supply, and long head of the triceps also will have partial nerve supply, and rest of the nerve supply and rest of the cutaneous sensations will be lost, just as the damage in the axilla. Next, the radial nerve occurs most commonly in the distal part of the groove. That is, the distal part of the radial groove, it most commonly gets injured because the origin of the nerve to the triceps and the cutaneous nerves will be at the distal part of the groove. So here the clinical features will be in such cases are like loss of extension of the wrist, because that is above to the wrist quite, and there will be wrist drop, loss of supination when the arm is extended, and sensory loss will be restricted only in the variable small area on the dorsum of the hand and between the first and the second metacarpals. Extension of the elbow is possible because it may be little weak because the nerves to the long head and the medial head of the triceps are given off in the axilla before the site of lesion. Next we shall see about the radial nerve injury at the elbow. So radial tunnel syndrome, that is the entrapment of the deep branch of radial nerve at the elbow, is called as radial tunnel syndrome, and this compression of radial nerve at the elbow may be caused by the four of the structures which I am going to talk now. One is the fibrous bands which can tether the radial nerve to radiohumeral joint. So that is the fibrous band. Sometimes it can compress the radial nerve. Next is sharp tendinous margins of extensor carpi radialis brevis, that also may cause compression of radial nerve. Then chain of vessels from the radial recurrent artery. If there is a hemangioma or abnormal chain of vessels of the radial recurrent artery may cause compression of the radial nerve. And arcade of Forci, that is a fibroaponeurotic proximal edge of the superficial part of supinator muscle. So the superficial part of supinator muscle will form a tunnel where the radial nerve is enclosed within the tunnel, because we know the radial nerve passes through the supinator muscle. So this supinator muscle, the tunnel, it may also cause compression of the radial nerve. So all these are the reasons for the compressions of the radial nerve at the elbow. So here the clinical features will be, there will be loss of extension of the wrist and fingers but no wrist drop, and pain over the extensor aspect of the forearm will be there. So there won't be wrist drop because the posterior interosseous nerve is already given off, so it will supply the extensor muscles, but still there will be pain over the extensor aspect of the forearm. So this completes the radial nerve injuries at each level, that is at the axilla, at the radial groove, and where distal part of the radial groove, and at the elbow. So I hope I made this topic easier for you all to understand the radial nerve, which is a very important nerve in the upper limb, which supplies most of the extensor muscles of the arm, forearm, and also on the dorsal side of the hand. So thank you. Bye.